Okay guys, following on from our sequence of x-rays, we're now going to talk about limbs. So we're going to demonstrate a caudal cranial hind limb and a craniocaudal forelimb x-ray. Again, there are adaptations to these. Yours might involve just the tibia and fibula. It might involve just the hind tibia and fibula, or the forelimb radius and ulna. It might not be particularly an elbow or a stifle, but most of the times there are some variants of these images. So I'm going to go with the standard settings for a craniocaudal elbow and a caudal cranial stifle. They will both be demonstrated in this video to give you an idea for your forelimb radiographs. So again, it's very similar to what we did last time. You may or may not have cassettes, you may or may not have grids. You probably will have to mention about what size you need, but you might not have to place them. So for those of you that do have to place them, I would recommend collimating to your plate first. Now, both of these x-rays are going to be a limb, so I'm going to use a small plate, and I'm going to collimate to my plate first so that I know no matter where I go, I am definitely in the right place when it comes to positioning my patient. The next thing I would do after that is obviously get my patient ready. So again, you're going to want to ask for assessment help here. I'm going to start with the stifle view, and as I mentioned before, I would always recommend the students consider supporting the head and assume someone is helping you nicely manoeuvre that back leg. For ease of positioning, and so I can demonstrate a little bit easier to you because it's easier to see this side and I can tuck the teddy off to this way, we're going to say we're doing a left hind caudal cranial stifle. So I would normally secure the other leg up, forward, out of the way, and just kind of tuck that tail to the side. If your patient's under sedation, you can't use tile tapes. Just as a reminder, if you've seen our earlier videos, we discussed that. But if your patient is under GA, you can, so you could always take that tail out of the way if you wanted to. But in this instance, my little teddy Labrador here, it's staying quite well. So what I'm going to focus on now is where I want to. So if you just pay attention to the Labrador for a second, the stifle would be here, okay? And then this is collimating around to where his tarsal joint would be, and then this is his foot. So already I'd probably be saying to my assessor, I actually need to put that leg a little bit further back. Think about on your teddy landmark, guys. I know I'm letting him fall for a second, but I'm doing this for demonstration. Think about actually on your teddy where your actual stifle is, because most people struggle with this task because you're not really thinking about your anatomy. Your hips up here, this would be the length of your femur, this would be your knee, this would be your tibia and fibula coming into your tarsal joint, and then moving your way down to your metatarsals and toes, or phalanges. So considering where actually your stifle is as you go into positioning, again, assessor would always be helping us manoeuvre him quite nicely. I just did that so you could see. So I want to try to put that stifle slap bang in my X, and I'm going to check where my X is so I know that I've got that right, okay? Now, again, if it's under sedation, you want to secure both the front end and the back end. If it's just under GA, you can secure just the area in question. I'm going to assume this is under GA, and therefore I only have to secure the area in question. But if it was under sedation and you had to secure both areas, then please do secure the front of the body as well as the back. I like to put wedges in to prevent rotation with these views, quite especially, to be honest. And I often find that sometimes a wedge just underneath that stifle just helps us keep it rotated straight, although as it happens, the stuffed toy here is doing that kind of for us, but I'm going to pop it in anyway so you can see a demonstration of that. And wedges either side to prevent him twisting too much, because it is a bit wonky. When you pull that leg back, they can sometimes get a little bit wonky. Now, it's a caudal cranial stifle. So guys, that means we're coming through the back of the leg and we're going out the front of the leg. Most people really struggle with this. Your landmarks, as you draw them, when your dog is like normal, down, okay? This is the front of their leg, that's cranial. This is the back of their leg, that's caudal. You're coming through the back of their leg and out the front. But on the hind version, I'm just showing you with my forearm, because obviously I'm not going to put my leg up on this table. So with your landmarks, a lot of you have been taught like cranial head, caudal bottom, and while that's all nice, what it doesn't help you do is understand it as a direction towards the front, towards the back, or towards the side. So try to imply them as if they're directions rather than exact points, and it will hopefully help you. That's a tip I give a lot of people that helps people with understanding where to say their landmarks. It's a direction, not an exact point. So for this one, I'm going to want to pop my marker on, and I said for ease, we're going to say it's a left stifle, which is exactly what it is, and I'm going to make sure my left marker's in my view. And then we're going to collimate in, and I can actually come quite close because I'm really only looking for that stifle joint. And then in terms of my length, I want to try to get mid-tib fib, so I reckon that's about as far as I could go. But my X is directly underneath where my stifle would roughly be there. I have not collimated really big because I'm unsure of what I'm doing. I have collimated to where would be my area of interest, coming down through the stifle as much as you can on a stuffed toy. And then I'd be happy to say my landmarks. So for this, I'd be centering over the stifle for a caudal cranial stifle. I would be coming proximally, which means towards up the leg or towards the top of the limb. I'd be coming to include normally the distal third of the femur. I'd be coming distally to normally the mid-tib fib is the answers on your exams, but I would bear in caution that in real practice people do prefer a full tibia length. I'm just adding that as a quick poke away, but for your exams, mid-tib fib would be perfectly sufficient, and medial-lateral skin edges or just skin edges would also suffice as well. So that's the caudal cranial. What I'm now going to do is pop the light back on, reset it as if we are doing a front leg, and show you how to do a front leg one as well. So again, pretend someone's holding my patient really nicely, and we'll go back to it. So we start with the exact same thing. Say the relevant size cassette you'd need. I would say small. Say if you need a grid, you don't need a grid because he would be less than 10 centimeters. Get your relevant cassette and collimate to your plate, which will be different from before because look, I actually collimated to my limb. So yeah, I'm glad that it's not in the right place because that shows that I collimated. Then ask your examiner to help maneuver your patient. And as if you've followed our first two videos, I discussed this a little bit more, but as the student, I always recommend everyone supports the head. You know, if you want, it's a bit awkward in here and I'm doing it for demonstration, but if you wanted to come up and support them upright and, you know, lift them really gently, then you can. And again, for ease of positioning, so it's easier for you, I'm going to say we're going to do a left elbow. So you want to pull that other leg back and out the way, and then they tend to tilt a bit, so I often find popping a wedge underneath their head works really well. The next thing is we need to reduce the movement of the head so that we've got, it's not in the way of our elbow. So again, I shimmy it naturally, I do it without realising, but I'm making it so that there's no sound there, guys, okay? And I'm just bringing it up and over here, just so that it helps lift him a little bit off out of the way. They can often be a little bit wonky, and obviously this stuffed toy is making it look extra worse, but the real models in your x-rays tasks actually normally have a little skeletal system, so they won't appear like that. Now, there is a fracture scenario of this. If there is, please do not hyperextend the leg, but if there isn't, then you're welcome to pull the leg slightly forward. And if you did have any rotation of the elbow in real life, you can pop a wedge behind it. This would not be necessary for your exams, but hey, if you learn it this way, you're going to show you understand what you're positioning, which is really good. And again, we're going to put our left marker. So now we're going to go to our collimation points and where we center. Again, if this was sedation, I would also secure the back end, because if they're sedated, you must secure both ends, but in both of these scenarios, I've ran them as if they are GA. And a reminder again, because it never hurts to say it more than once, if it's under GA, you can use tapes and ties, but you cannot, if they are under sedation, use tape or tie. So we want to center over the elbow, which is where we are. I'm going to collimate in quite nice and close. I'm going to bring that in, and that's probably about as far as I can go. So I've centered over the elbow, I've collimated proximally again, which means up the leg, to around the mid-humerus, distal third of the humerus, and I've come again distally to the mid-radius and ulnar, and again medial lateral skin edges. And that would be a cranial, because we're coming through the front of the leg, caudal elbow. And I shall reset this, ready for another set of x-ray views. But I hope that helps. Give us a follow if you have any questions. We're always available for emails, so ping us over an email at any time.